Welcome, everyone. Thanks, Anthony. So I'm very excited to start off the course this morning, and I'd like to introduce our first speaker. He is Dr. Brian Feeley, and we're excited to hear from him on shoulder problems that you may see in your office, and then have a live demonstration on how to examine the shoulder and identify those injuries. So to introduce Brian, he's the Chief of Sports Medicine and Shoulder Service here at UCSF. He's a professor in residence. He is from this area, grew up in the Bay Area, and then went to Stanford University for his Bachelor of Science degree and his MD from Stanford. And then he went down to UCLA for residency in orthopedic surgery. He then moved to the other coast and completed his sports medicine and shoulder fellowship at the Hospital for Special Surgeries in New York City, where he was also a team physician to the New York Giants. He came to UCSF in 2008 and has been with us ever since. So I'm sure you'll all learn a lot, and we're excited to have him present with us this morning. Thanks very much, Brian.
All right, thank you. It's a little bit awkward because normally I try to make eye contact with the people I'm giving a talk to, but I guess I'll make eye contact with the pictures of shoulders. So these are my disclosures. I receive research support from a variety of places. I'm on a couple editorial boards, and I have stock and effort in research associated endeavors with these companies. So what we're going to cover today is a little bit of shoulder anatomy. We're actually going to skip that, but it is in the syllabus. We're going to talk about the physical exam in the next section. We're going to talk mainly on this section about common chronic shoulder problems, including rotator cuff problems, frozen shoulder, arthritis, and biceps tendonitis. We'll get caught up with some of the more recent updates in the literature, and we'll touch a little bit on zebras, especially if you have questions about them. So even though shoulder pain is something that often gets to be feeling fairly confusing, remember that at some point in almost everybody's training, we memorized a lot of different causes and differentials that were a lot more complicated than shoulder problems. So in a nutshell, what I'm gonna try to cover is what the common problems you're gonna see, how you get to the bottom of these efficiently, and effectively answer the questions that patients are gonna have about these problems. So just a little bit about the anatomy of the shoulder. If you remember, your shoulder is actually two joints. It's the glenohumeral joint, which is the ball and socket joint, as well as the scapula moving along the rib cage. So it's two joints that move to give you your full range of motion. In the interest of time, I'm going to skip through these slides, and we will cover this just mainly more in the exam part. So when we look at what problems we see in clinic, in looking at over the last year in our clinics, this is the most common differential diagnoses that we see. About 45% of shoulder problems encompass rotator cuff tears, whether that's impingement, partial thickness, or full thickness tears. About 15% in our clinic is shoulder arthritis. About 15% is frozen shoulder. That's actually increased with COVID. We'll talk about that a little bit. We also see biceps problems, and in a specialty clinic where we see a lot of young athletes, we also see dislocations and fractures. And don't forget, in some cases, this can be lupus, Wegener's, or all the other things that can present as shoulder problems if you're outside of a sports medicine clinic. So when I look at these problems, I think you can divide out these common problems by how they are going to present, and we're going to go over these over and over. So for rotator cuff tears, the pain tends to be lateral, so it tends to be more on the outside of the shoulder. Patients tend to have pain at night, pain with overhead activity, and as the tears progress, they'll often have true weakness or a report of weakness, which I think is important to differentiate out. For shoulder arthritis, the pain tends to be more posterior, tends to be more consistent pain, and there tends to be loss of motion. And the one that this overlaps the most with is frozen shoulder, because the pain is everywhere but can be anterior or posterior. The pain is all the time, and there is loss of motion. The main way you differentiate this is with an x-ray. And biceps tendonitis, which is extremely common, especially in your 30 to 50-year-old population that is a little bit more active. There's pain anteriorly, there's pain with activities, there's no loss of motion. The pain really can be focused on one particular spot. Because we tend to run a pretty busy clinic, I like to figure out what the easiest way is to get through a shoulder history and physical without having to do too much work. And I really like to ask 4 questions and then start differentiating after each question. So the first question I usually ask is, was there an injury? And this is asked on our patient intake sheets. And if there was an injury, you want to think, could this be a fracture? Or this could be an acute rotator cuff injury. And really, that's going to differentiate from how we're going to evaluate those patients. There's a lot of pain, they're having difficulty moving, they really should get x-rays and then be referred relatively quickly to orthopedic surgery for a more thorough evaluation. Most of the time, if you can't elevate your arm or there's signs of a fracture, then realistically it should be evaluated in one of our clinics. If there wasn't really an acute injury, or it doesn't sound like enough of an injury to really have created a broken bone, there's no real fall, I ask, where does it hurt? Because that location of pain is really important. And like we talked about, laterally is going to be rotator cuff, posteriorly is shoulder arthritis, kind of all over the place is frozen shoulder, and in the front is biceps tendonitis. The next question I ask is, are you losing range of motion? If you're really losing range of motion, think arthritis or frozen shoulder. And if you're losing strength, think rotator cuff injury. Patients, even if they have smaller rotator cuff tears, will feel like there's a difference in their strength, especially for doing things. The question I like to ask is, if you're pulling something off of a shelf and you can pull that down, is that more difficult than it was before? So even if they're not frankly weak, are they subjectively weak in their doing their daily activities? So I like doing this in a case-based way because I think it's most germane to most of our practices. So the first case is a 58-year-old male with 6 months of shoulder pain. It's mostly lateral, hurts at night, pain with overhead activity, but no real weakness. And he says he can't lift at the gym quite as well as he could before, but he can still do squats standing on a balance ball. So as you think about this, these are the most likely diagnoses that come in. It could be frozen shoulder because, frankly, it can always be frozen shoulder. It could be more of an impingement type sign where you have inflammation but you don't have a rotator cuff tear. Could be a rotator cuff tear, but he's not really truly describing weakness. Cervical radiculopathy tends to be shoulder-related pain, but usually extends all the way down into the hand. And as we get older, it can always be shoulder arthritis. So when you think about these questions, the way it was described, was there an acute injury? Not really. Sometimes patients will describe, well, I was in the gym and I had some pain there, but it really wasn't an acute injury like a fall. He describes his pain as laterally, isn't really losing range of motion, but does describe a little bit of strength loss or a change in how his shoulder feels. So when I think about rotator cuff disease, I think about it as really a spectrum of disease. It starts with impingement or inflammation above the rotator cuff. You can progress to partial tears. You can have full thickness tears, and as those progress, they really can become what we call massive tears or tears that aren't really repairable. So I really like analogies because I think they help explain to patients exactly what's going on. So this is a picture of what impingement looks like inside the shoulder. So this is looking above the rotator cuff. And the way I like to think about this is like having leaves on your roof. You have some inflammation or leaves above your roof. Oftentimes, just a stiff wind will blow the leaves off. That's the same as doing a little bit of physical therapy or taking anti-inflammatories, and that'll go away. Sometimes you have to be a little bit more aggressive, and we can do a surgery where we essentially get up on the roof and clean this out, and we do that with a relatively straightforward surgery to take a shaver or essentially a vacuum cleaner with teeth and remove the impingement. But most of the time, this is going to get better on its own. Partial tears are slightly different, but in many cases, these are relatively benign. And the way I describe this to patients is that your rotator cuff is like the roof of your house. There's a top side where the shingles are, and there's a bottom side where, like this room, there's awkward roofing. A partial tear means that there is imperfections in the rotator cuff, but they don't go all the way through. So the example of a bursal-sided partial tear is seen here. And you can imagine if this is like a roof, you're missing some of the shingles right here. So the rest of your rotator cuff is fine. It's a little bit thinned out, but in many patients, this is entirely normal for age. A bursal side or undersided tear, this is looking inside the shoulder and looking up at the rotator cuff. You can see that it's not quite as perfect. It's a little bit more thinned out, kind of like having a little bit of a chip in the ceiling, but overall you're probably going to be okay. Now, impingement, which is what we've classically talked about as inflammation above the rotator cuff tear, is thought to be impingement under the acromion when you flex and internally rotate your shoulder. And you take that area above your rotator cuff and cause inflammation. And the way I like to think about it is that it's not necessarily a weakness in the rotator cuff, but it's an imbalance. As our deltoid gets stronger relative to our rotator cuff, as we raise our shoulder up, your shoulder moves up a little bit and can impinge or cause inflammation. It's not a bone spur per se. Oftentimes patients will ask, well, what about this bone spur that's seen on x-ray? The bone spur actually sits inside your CA ligament, and whether or not you have a spur is more age-related than symptom-related. So it's more an imbalance of muscles and how that affects the tendon and the bursa above your rotator cuff. It's not having a bone spur that's pushing into your rotator cuff. So in terms of management of impingement and partial thickness rotator cuff tears, there's really good evidence that our primary treatment should be non-operative. So this was a nice study that came out a couple years ago now, where they updated all the systematic reviews examining the effectiveness of conservative physical therapy. I don't know if there's non-conservative physical therapy, but I think they meant just without ultrasound, without any injections. And they looked at whether or not essentially regular physical therapy or more hands-on physical therapy worked. And what they found was almost all studies show that physical therapy gets patients to the point where they're feeling better, but it works a little bit better if physical therapists are putting their hands on the patients. And so what I do in my physical therapy prescription is I write down, please do hands-on manual therapy, do some stretching, and I think that helps patients. Now, what about surgical management for subacromial decompression or bursectomy? It was a surgery that was done a lot in the 90s and 2000s, but what we found over time is that even though it's a safe surgery and it is effective, that in the vast majority of patients, they will get better with non-operative management. So it's something that we can do. It's a very safe surgery. You're only in a sling for about a week after surgery, but it's not something that's necessary for most patients. So my algorithm, when patients come in with impingement and partial thickness tears, no real weakness on exam, depends on how much their symptoms are. And for me, it's a lot about how well they're sleeping. So if they have mild pain with activity, a little bit of night pain, they're still really doing their activities, I'm going to recommend physical therapy and anti-inflammatories. And if they get better over the course of 6 to 8 weeks, I'm going to transition them to a home exercise program. If they don't really get better at that, some patients can have a small full thickness rotator cuff tear. So I will get an MRI after 6 to 8 weeks of physical therapy. If it doesn't show a full thickness tear, then I will offer them a steroid injection, which we'll talk about a little bit down the line. And if they really aren't getting better, then I will consider surgery. And it's the exception, not the rule, that patients will progress down into the surgery pathway. If they have moderate pain with activity, if it's waking them up at night, if it's waking their partner up at night, which is often what brings these patients in, it's there and like, my shoulder's fine, but their partner says it's fine, but I'm being kept up all night, so please fix it. I'll do physical therapy and anti-inflammatories, and I'll consider a single injection at that time in the subacromial space to just get them accelerated on that path to recovery a little bit faster. Most of the times, patients will get better at that point, and they'll transition to a home exercise program. If not, again, they'll get a MRI to evaluate for any significant full-thickness rotator cuff tears. So what do patients really want to know when you tell them they have partial thickness tears? Well, what they really want to know is, will you get better? And the answer is yes. A vast majority of people will get better, and only about 30% of them will progress to a full thickness tear over the next 5 years. So having a partial thickness tear does not mean you're going to get a full thickness tear. It is often something that is normal for age. So you will get better, and it is not necessarily guaranteeing you are on your way to your shoulder falling apart. Do you need surgery? Absolutely not. For the most people, if you have a partial tear and impingement, surgery is not going to be beneficial. We rarely should be operating on patients with partial tears and impingement, so go do some physical therapy. And the most common question you get is, will I damage my shoulder if I use it more? And you won't. There's no evidence that increased recreational activity is a risk factor for progressing a rotator cuff problem. So it might hurt a little bit more if you have some inflammation above your rotator cuff, but go out, play tennis, play pickleball, go skiing, do whatever you want to do. It's not going to make that tear worse. Okay, so unfortunately he comes back. He's now had about 9 months of shoulder pain. It's mostly lateral, still hurts at night, pain with overactivity. He's not really weak, but he's really stopped his gym activities. He gets an MRI from the local surgeon, who's recommending surgery for a small full thickness tear. But he's got this awesome trip. He hasn't traveled since COVID. He really wants to go to Europe, and he doesn't want to cancel this trip. And he wants to know, do I need to have surgery now? So I think when we talk about full thickness tears, this is a different pathology. And what I tell my patients is, this is like having a hole in your roof. A hole in your roof can be really, really small, or it can be huge, where the entire roof essentially blows off, and that's a massive tear. If you have a small full thickness tear, location is really important. And that's kind of like having a tear right above your bed, or having a hole in your roof right above your bed. Anytime it rains, you're going to get wet, versus having a small hole in your garage, you might be totally fine with it. And what we know is that the tears, even if they're small, so this is a small full thickness tear, we can see the edge of the tear here. So this part of the rotator cuff should be attached all the way over here. If it uncovers the biceps or disrupts the rotator cuff cable, those patients tend to be more symptomatic. So the questions we get for patients once they know that they have a full thickness tear, they really want to know what happens when you have that tear, what happens if you don't fix it, especially right away, and what happens if you do fix a tear. How good are the outcomes? Because almost every patient has a history of hearing a friend that says, I've had a rotator cuff problem and it was a disaster. So when do these patients become symptomatic? I think one of the important things to understand is, as we get older, having a rotator cuff tear for a majority of people is not actually symptomatic. So many patients will have a rotator cuff tear, go their entire life, it's full thickness, and not have symptoms. But we know that when some patients have tears that get a little bit larger and their function decreases, that is when that tear is getting bigger, and that is often when they're presenting. So it's important to tell your patients, well, you may have had that rotator cuff tear before, but it's that progression of tear over the last 3 months, 6 months, that is probably what's causing symptoms. So if you don't fix a rotator cuff tear, I think this is really important, because if the natural history is that many of these patients are going to be asymptomatic or don't need surgery, we need to know what the natural history is. So like we talked about, we know when people become symptomatic, the tear is getting larger, and that critical size tear, when that tear is really going to become functionally important for that patient, is based on location. So again, this is that tear where the biceps is uncovered, and as the tear size progresses, especially from the mid part of the rotator cuff to the front to back, and gets to be greater than 2 centimeters in diameter, those are patients that are going to become more biomechanically compromised. We also know from really nice studies out of WashU that the location is important. If you've uncovered the biceps, your muscle is going to start degenerating, and that rate of progression tends to be a little bit greater. We also know that as you get older, as the tear gets bigger, and as you develop muscle changes on your MRI, the risk factors all increase, and they all kind of add together. And the way I like to think about this is kind of one of those gravity plots. So tears progress because as we get older, the overall strength of our rotator cuff gets a little bit weaker. That's probably the biggest factor. The second biggest factor is muscle deterioration. As the muscle degenerates, you don't have the same pull on your rotator cuff. That seems to push towards tear progression. As the tear gets bigger, it tends to beget more progression. And there are also metabolic factors. So how healthy you are in terms of especially diabetes and controlling your blood sugars tends to be an independent risk factor. Now, when you look at these, unfortunately, the only one under our control is the metabolic risk factors. But telling patients, you have some control over this by getting a little bit of a healthier lifestyle, I think is important, and it's something that we can do to intervene for patients. So what happens if you don't get rotator cuff tear fixed right away? So Dr. Moosmeyer, who has some really well-known studies, and we'll cover some of these down the line as well, did a really nice study where he looked at 50 patients in Norway, looked at asymptomatic patients that came in, were enrolled in a study and were found to have a full thickness rotator cuff tear, and looked at them over 3 years and found that less than 40% of those developed symptoms. And not surprisingly, like we talked about, those patients that had bigger tears versus those that didn't have symptoms, the people with bigger tears were the ones that were more likely to develop symptoms. So really, really small tears in your rotator cuff, those small holes in the roof, may not even progress, but those patients with bigger tears were the ones that were more likely to progress, and they were more likely to progress to have muscle changes as well. So the patients that are having those bigger tears are the ones that are naturally the ones we want to keep more of an eye on. So what should you do about these patients? So this is a nice study done in a multi-center fashion, which was done in a prospective cohort trial. And they looked at doing physical therapy for treating atraumatic full thickness tears. The protocol was 6 to 12 weeks of rest, some gentle activity modification, anti-inflammatories, a pretty standard physical therapy program, and an injection if they wanted them. Now, it's important that these patients were patients that did not want rotator cuff surgery. And what they found was that it didn't matter how big the tear was. It didn't matter how functional they were at first. The most important thing was whether or not the patients thought that physical therapy was going to get better. And what they found was that at 6 weeks, the patients that responded to physical therapy had a good outcome, and this progressed for 12 weeks. And we have now seen this progress from 12 weeks to 1 year to 2 years, and now to 5 and 10 years. This study is now 10 years old, and only one patient that completed the non-operative course has gone on to a reverse shoulder replacement. So the vast majority of patients that do physical therapy and are happy are going to continue to be happy. So the summary I have for patients is if you're not weak, it's okay to try non-operative therapy. There's a very good chance you're going to be successful at 1 year. And if you're not happy, you know that physical therapy hasn't worked in about 6 weeks, so you're not wasting that much time. Now, what about steroids? I think steroid injections get a lot of different data. And in the rotator cuff, there are multiple studies that show that subacromial injections, which is what we usually do for rotator cuff tears, have a higher risk of infection if you're going to have surgery within 1 month. So if you are trying to bridge to the time of surgery, I don't think it's a good idea. You have a higher risk of recurrent tearing if you have surgery within 3 months after a subacromial injection. So my protocol, if a patient comes in and says, well, I just had an injection, you're going to wait at least 3 months before you have any surgery. And multiple injections seem to be worse for you than single injections. So my protocol is I will try an injection, especially for somebody with a partial thickness tear, but I don't think it's a good treatment option for somebody with a full thickness tear, because I think those patients are going to be more likely to respond to physical therapy. If they don't respond to physical therapy, then I would recommend that they have surgery. Now, what happens oftentimes is patients want to know, well, gosh, I know I've got this rotator cuff tear. I want to get it fixed, but I'm really just too busy. And this happened particularly with COVID, when we also had a fair amount of forced delays. So Albert Lin and his group in Pittsburgh did this really nice study where they divided patients into 2 groups, fixed within a year and fixed between 1 and 2 years. And what they found was that there was no difference in re-tear rates or patient-reported outcomes. So what this tells us is that if you have a patient with a rotator cuff tear, yes, they may want to delay surgery, and within 1 to 2 years, it's probably safe to do so. But I will couch that most of these tears were smaller tears, less than 2 centimeters, so those would fall into the ones that aren't progressing quickly. So it's probably okay for these small tears, so just keep an eye on them, see how they're doing, and consider surgery, but it doesn't need to be something that they change their summer plans for. As we know, if you wait years and years and years, there is a risk that this becomes an irreparable tear, but this is over the course of years. So this was a nice study done out of WashU that looked at when does this change from having healthy muscle actually happen. And what they found was that from asymptomatic tears, those tears don't tend to enlarge until about 1 to 4 years afterwards. And muscle changes start happening at least 1 year afterwards, and those are pretty subtle early on. And it takes 3 to 4 years before those muscle changes are probably irreversible. So I keep patients that don't want surgery, I will keep an eye on them. And if they start changing their symptoms, I think that's a marker of tear progression. Now, when we do fix a rotator cuff tear, it is a surgery that we say is largely for delayed gratification, but it does tend to work pretty well for the right patients. And this has been shown in a few studies recently. Nitin Jain, who is a really strong non-operative sports medicine doctor, mentally strong, I don't know how physically strong he is, did this propensity score study where they looked at patients and they were treated either non-operatively or operatively, and found that even as early as 6 and 12 months, the patients that were randomized into this group were doing better than the people treated with non-operative management. So with it, for younger, especially higher demand patients, and if they're not happy with physical therapy, even at a year afterwards, those patients are going to be doing better with surgical fixation. And then going back to one of the other studies that Dr. Moosmeyer did, I think this is the most important study. So they looked at patients at 2 years, 5 years, and 10 years in a randomized controlled trial of physical therapy versus surgery for full thickness rotator cuff tears. And these patients started off symptomatic. And what they found when they published their first study is at 1 and 2 years, there was no statistical difference between physical therapy, shown in the dotted line, and surgery, shown in the dark line. However, at 5 years, what they found was there was a small difference, but it didn't meet clinical significance. So the physical therapy group wasn't doing quite as well, but most of them were still pretty happy. And the ASES score in the 80s is frankly doing pretty darn well. But at 10 years, the patients that had surgery were doing now statistically different, and they were meeting the minimally clinically important difference. So this suggests that for your patients that are younger, like under the age of 65, they're higher demand, they have this health span of at least 10 years of being really active, they may be somebody you want to think about fixing in the next year or two. Now, our outcomes of rotator cuff tears are overall pretty good, but they are dependent on how big the rotator cuff tear is. So smaller tears tend to do better. There's better muscle quality. There's a lower rate of re-rupture. It's easier to do the rehab because the muscle is a little bit stronger. And there are better long-term outcomes. So I like to get to these tears before they've really progressed. That's not always possible. But we know that in these smaller tears that are symptomatic, that don't get better with physical therapy, they will do better with surgery than just continuing to do physical therapy. So this is my algorithm for full thickness tears. Acute tears, like they fall down, they have an injury, they are largely going to go towards surgery. So those are ones we want to see sooner rather than later. But these chronic degenerative tears, if they're weak on exam, I will consider physical therapy and an injection, but that weakness is often something that'll drive patients towards surgery. If they have a small full thickness tear, but they're not really weak, I'll do physical therapy, consider a single injection. Surgery only if they're really adamant, because I don't think it really changes their outcomes that much. For the most part, patients without weakness tend to do pretty well with a small rotator cuff tear. So what do these patients really want to know? Will you get better? Yes, but your tear will not actually heal, and that's got to be okay with you. You will still have that hole in your rotator cuff. Do you need surgery? Well, you may actually do better with surgery if you're going to be higher demand, you're planning on being athletic for the next decade or so. And will you damage your shoulder if you use it more? Actually, we don't have any data that says you're going to make that rotator cuff bigger by doing activity. The risk factors are you're getting older, if that tear gets bigger, and if you have metabolic conditions. You can still go out and play pickleball. If you don't have enough rotator cuff, I have a whole additional talk if you want to look at it, which talks a little bit more detail about these studies and others, but that's probably enough rotator cuff. So we're going to transition to some other problems in the shoulder. So this is a 54-year-old woman. She presents with 4 months of shoulder pain that occurred after taking her jacket off. She has pain everywhere, sometimes into the elbow, sometimes into the back of the shoulder. She can't get things off of high shelves, can't put her belt on. Your colleague got an MRI. It shows a partial thickness rotator cuff tear and a labral tear, and she really wants these fixed. So when I think about these diagnoses, oftentimes patients come in. Oh, now we're doing a poll, okay? All right, now people are figuring out to do the poll. Awesome. Okay, let's see. Are we sharing the results? Okay, well, now I can't do it. Okay, so most people picked frozen shoulder, so 41%. 26% said labral tear. That is probably going to be wrong. We'll talk a little bit about why. Shoulder arthritis, you can't tell. It is going to be less common than frozen shoulder, but you need an x-ray. And then rotator cuff tears, yes, they have a rotator cuff tear, but when they're limited in their range of motion, those things like I can't reach behind are hard. But the most important thing is you can't really tell until you ask a few more questions. So let's ask this patient a few more questions. Okay, so was there an acute injury? Not really. Does it hurt everywhere? Losing range of motion. If you really ask the patients what's your number one problem, if they have frozen shoulder arthritis, is they can't reach. They physically cannot reach, but they're not really losing strength. They can do things within their range. And these are your reasonable patients that come in and are now acting unreasonably. So these physical exams are really easy. Once you look at a patient with frozen shoulder and you figure out it's frozen shoulder, you never forget it. So when you look at them, they cannot raise their arm up and they cannot reach behind their back. You don't need to do any palpation. I test their motion and I don't do any specific testing on these patients because it makes them miserable. So frozen shoulder is also known as adhesive capsulitis. And when you ask that, what I ask is, did you really have a true trauma? I had a patient yesterday who said they fell down, but they didn't even land on that side. And then now they can't reach to the back of the car. They complain of limited range of motion, and they will say that fast motion hurts more than slow motion. This is extraordinarily common. It's the second most common cause of shoulder pain in the United States in patients between the age of 40 and 60, which is when most patients see the doctor. The causes are relatively unknown. It's associated with thyroid and diabetes and things that ramp up the immune system. And there seems to be, not surprisingly, an increase after COVID. So we see an increase in frozen shoulder, especially about a month or two after patients were diagnosed with COVID. The natural history of this is that you have three phases. You have a freezing phase where the shoulder is getting worse and worse and worse. A frozen phase where it doesn't really hurt, but you can't move. And then this long thawing phase. And I think the pain part of this is kind of non-specific because patients hurt all the time during this. When we look inside the capsule, what we see is histologically, we see a lot of inflammatory cells, and this bright pink is collagen. So the inflammation stimulates this collagen deposition in your capsule, and the capsule gets thicker and thicker and tighter, and the patients physically just can't move. So there's 4 reasonable treatment options for this. There's do nothing, physical therapy, injections, and surgery. Do nothing works totally fine. The problem with doing nothing and talking to patients like we're going to do nothing is that patients are pretty frustrated with frozen shoulder. And this was a really recent study that came out that basically talked to patients about what it's like living with frozen shoulder. And it has a pretty considerable impact both on their personal and on their social-cultural level. So a lot of patients will stop doing their physical activities. They actually stop hanging out with their friends as much, score higher on their depression scale. So at the very least, if patients don't want to do anything for frozen shoulder, I try to convince them to, if it's possible, to at least take anti-inflammatories and try to maintain as much of their physical activity as possible. When patients are treated with essentially benign neglect, the average duration of symptoms is 1.6 years, but almost everybody gets better. So what can we do to kind of accelerate these treatments a little bit faster? So one thing is we can do steroid injections. So this is an indication where I think steroid injections are really, really helpful. You could either do lower high-dose steroids, but I think higher dose steroids tend to work a little bit better. Works better if we do it under ultrasound, so I do not do these in clinic. I send this to my partner, Dr. Berrigan or Dr. Hadamiya, to do this under ultrasound. There's really no considerable side effects for these injections. They're not going to cause deterioration. They tend to make patients better faster. What's new in this is whether or not we should add a suprascapular nerve block so you can block the nerve to the capsule. And it seems to help patients do their range of motion exercise for the next 6 weeks or so. It wasn't necessarily more effective than injection alone, but it made physical therapy easier. The other thing we can do that's relatively new is hydrodilating the shoulder. So what Dr. Berrigan will do is he'll do an injection into the shoulder and essentially put as much volume as he can into the shoulder. And what's interesting is it doesn't really seem to help motion all that much more than doing it normally, but it helped patients feel better about their shoulder. So they weren't as afraid to move their shoulder, which means they're going to participate more in physical therapy, and they weren't as depressed or anxious with having frozen shoulder. So all these feelings of I can't do the things I want to do seems to be relieved with being a little bit more aggressive with these injections. Physical therapy seems to improve pain and function and motion, but only a little bit. So most patients will get a little bit of a bump with physical therapy. They tend to do better with physical therapy towards the end of frozen shoulder. So what I've been doing in the last couple years is doing the injection, telling patients to do a home exercise program, and then follow up in about 3 to 4 months. And as they're feeling better, their range of motion is returning, then do physical therapy. We almost never operate on frozen shoulder. Anytime I tell patients they don't need surgery for this, they're usually really relieved, because the idea of operating on an irritated shoulder only makes patients feel like it's going to get worse. There is no advantage to doing anything for like stem cells or PRP at this point, but we are considering starting to do a study to see, is there a value in certain types of PRP, which has potent anti-inflammatory properties. If you really want to read more about uncurable disease processes, this is a really nice article that came out by one of our former residents, Dr. Moore, and one of my mentors, Scott Rodeo. It's a 3-page Nature review summary of frozen shoulder. It's really well done, and I would highly encourage it. Takes about 15 minutes to read and understand that we really don't understand that much about frozen shoulder. So my protocol for loss of range of motion is get x-rays, and we'll talk about that in a second. Depending on what the x-rays show are really going to guide treatment. If they don't show any arthritis, then by definition that loss of passive range of motion is frozen shoulder, and this is my treatment protocol for this. So what do patients really want to know with frozen shoulder? Will you get better? Yes, but it's going to take time. Do you need surgery? You absolutely do not need surgery for frozen shoulder, nor should you have it. And will you damage your shoulder if you use it more? No, you won't, but it might hurt more, but try to go out and use your shoulder. Okay, so same case, but she's a little bit older now, 67, 4 months of shoulder pain that occurred after taking her jacket off. Pains mostly in the back of the shoulder, sometimes in the front. Has trouble getting things off high shelves and can't put her belt on. If you look at this is the exact same story, and this is why we get x-rays, especially as patients get older. This is her x-ray. So over 55, please do not get an MRI. Please start with an x-ray, because this is a patient that's compensated for years and years and years, but has developed shoulder arthritis. Again, the protocol is going to be the same, but we're not gonna push non-operative management necessarily, because with arthritis, the non-operative management doesn't necessarily work. If they're really limited in their activities of daily living, I'm going to recommend surgery, because it's going to work better than physical therapy or an intra-articular injection. But if they're only mildly limited and it's not really affecting them, we can certainly try non-operative management. So the non-operative management for shoulder arthritis, there's no good data in the last 8 years that anti-inflammatories work other than for daily maintenance. Physical therapy has been shown to be mild to moderate relief that gives you about 8 points of improvement, which does not meet minimally clinically important differences. Injections tend to give a solid 1 to 2 month improvement. There is some evidence that viscosupplementation in a single study worked, but it's not approved for shoulder, so usually insurance doesn't cover it. And PRP, there's absolutely no evidence that it works for shoulder OA. Surgical treatment for shoulder arthritis tends to work. Most people stay overnight in the hospital. They wear a sling for 6 weeks, and they'll have about 80 to 90% recovery with excellent pain relief. Complications are really rare. About 1 to 2% of patients will have a complication, but for most patients, it's very much like a hip replacement. It tends to work really well. What's new for patients is, as we've gotten more technologically advanced, we can do a less invasive surgery, which a lot of patients like. A lot of times this is more patient specific, so we get a CT scan and we design what surgery we're going to do to be very specific for those patients. What patients really want to know about shoulder OA, and then I'll stop after this and we'll transition to the exam. Will you get better? Yeah, oftentimes when we see patients with a flare of their arthritis, whether it's hip, knee, or shoulder arthritis, it's a stepwise deterioration. But we can just keep an eye on you. There's no rush to surgery. Will you eventually need surgery? Yeah, if you have an event horizon or a lifetime horizon of 10 to 15 to 20 years, you're probably going to need surgery. But there is no rush. You're not going to make the arthritis worse by using your shoulder any more than time, and it's not going to really change your outcomes. So I'm going to skip the part on biceps tendonitis, and we'll talk a little bit about it during the exam. And so I'm going to stop sharing my screen, and then we will transition to the physical exam part of this.